So this presentation is an introduction to the various techniques used in imaging the human collecting system. It's not meant to teach you how to read all these various radiographs. It is, however, meant to give you some pattern recognition into the various pathologies that affect the renal system, the kidneys, the ureters, the bladder, and the associated vasculature. And what is surgical imaging? Besides x-rays, we can image the collecting system directly using fiber optic endoscopes. And we'll look at some of those modalities and how they can also treat as well as diagnose your patient. I've updated this PowerPoint from last year, so make sure that you have this most current PowerPoint that says revised and updated March 28th, 2020. Here on the initial slide, we're just scrolling through a CT scan using BodyViz, looking at the kidneys in the retroperitoneum. And I'm just simply showing some of the anatomy here in the retroperitoneum as we move up and down through the kidneys, looking at not only the renal vasculature, but in this case, we can see the renal vein, the renal artery, we can see the renal pelvis, etc. So, some of our learning objectives, you should be able to recognize some normal urological radiographic anatomy. You just should be able to describe the indications for imaging in renal disease and to talk about some of the various techniques that we use when we image the retroperitoneum and the kidneys. And you should be able to discuss the advantages and disadvantages of ultrasound, CAT scan, MRI versus MR angiography, i.e. MRA. What is a KUB versus an abdominal film? What's the difference? What's an IVP? It's a tomographic study, and how is that similar to a CAT scan? What is a nuclear medicine scan of the kidneys, also called a renal scan, and it's used for function? How is it used for function? What's a cystoscopy? What's a ureteroscopy? What's a percutaneous nephrostomy tube? What's a voiding cyst urethrogram? That can also be cystourethrogram. It's not a typo. And what's a retrograde pyelogram? Continuing, so I want you to list some of these common imaging techniques to be able to know what they are, what they look like, and how you'd use them. Tell me the difference between a KUB and an abdominal film. What does KUB stand for? Well, you know from H&H it stood for kidneys, ureters, and bladder. And there's a difference between just an abdominal film and a KUB. What is a renal scan used for? Well, it's used to assess for renal function. What is the radioactive chemical used for renal scan? Technetium, just like so many of our other radioactive scans. Can you identify on a renal ultrasound a renal cyst? And did you read the paper on slide 16 entitled Evaluation of Incidental Renal and Adrenal Masses? You might as well read this paper now because we're going to talk about incidental adrenalomas in the endocrine course that you take next year, and to understand how the adrenals and the kidneys, which are adjacent to one another anatomically, how they can appear sometimes together as one unit on a CT scan. Who was Dr. Röntgen, and who's given credit for discovering x-rays? Was it Röntgen or was it Tesla? Can you tell me the difference between a bladder stone and a phlebolith? What's a nephrotomogram? Is a CT scan of the kidneys a nephrotomogram? I'll give you a hint, it is. Is an IVP a nephrotomogram? Yes, it is. Is a KUB? No, it is not. What is the difference between an IVP and a simple post-CT nephrogram? Well, an IVP is a tomogram, as is a post-CT nephrogram, but an IVP is simply just a plain X-ray, which is used to create the tomogram of the kidneys, whereas the nephrogram done after someone has a CT scan is actually just residual intravenous contrast left in the collecting system that you can take a picture of with a simple plain X-ray, and you can see those. And we'll show you what those look like. Can you identify the kidney stone on an IVP? Can you see a kidney stone on a non-contrast CAT scan? And where anatomically do most kidney stones occur? What is a cystogram? What's a cystoscopy? What is ureteroscopy? Can a cystogram be helpful for assessing an enlarged prostate gland? If so, how? What is a TURP, a transurethral resection of the prostate? How is it performed? What are bladder trabeculations and what causes them? We mentioned this. A renal gram using radioactive chemicals is useful to determine renal function. How? How is it used? And why do we want to know sometimes the function of the individual kidneys, the left kidney versus the right kidney? What is hydronephrosis, and can you recognize it on an IVP, a CAT scan, a renogram, an ultrasound of the kidney? And what are some of the causes of hydronephrosis? As you can imagine, hydronephrosis just means a big enlarged kidney, usually because something is blocking the kidney downstream. What's a percutaneous nephrostomy tube? How do we use them? And is it helpful that the kidney is actually in the retroperitoneum when we're draining a kidney that is affected by a blockage or an infection? And why is the fact that it's retroperitoneal a good thing? Can you recognize a solid mass versus a cystic mass on an ultrasound of the kidneys? What's nutcracker syndrome? How's it diagnosed? How is it treated? And how does nutcracker syndrome differ from SMA syndrome? And how is SMA syndrome diagnosed and how is it treated? We're not done yet. What's the gold standard for the diagnosis of kidney stones? I'll give you a hint. It's a non-contrast CT scan. What is lithotripsy? Yeah, well, we put a patient under general anesthesia and we blast their kidneys and their ureters with sound waves. What is ureteroscopy? It's putting an endoscope up someone's urethra, past the bladder, into the ureters to pull out kidney stones or to biopsy tumors. What is pyelonephritis? What are some causes? Should chronic nephritis or a chronic urinary tract infection warrant attention? Why? Why is that important to know that? What are some features of renal cell carcinoma and what's unique about this tumor in how it spreads? We'll see some pictures of this coming up. Who is credited with discovering an MRI that can create an image? And then what's the unit of measurement for the strength of a magnet? I'll give you a hint. It's called a Tesla. What is a classic angiogram and how does it differ from an MRA or a CT angiogram? What is renal artery stenosis? How is it diagnosed? Can you hear a bruit on physical exam to diagnose it? Sometimes. What is the treatment? Usually it's by dilatation or putting a stent in. And what is the symptom of renal artery stenosis? Hypertension. What is retrograde urethrogram? What is a retrograde pyelogram? What is urethoscopy, cystoscopy, ureteroscopy, and what is a voiding cyst urethrogram? And most importantly, when we talk about CT scanning, sometimes the Beatles come up. Why is their name associated, especially Apple Records, why is that associated with the discovery and financing required for the discovery of CT scanning and images? And then, did you watch my YouTube playlist on renal anatomy and some of the renal procedures that I talk about? So we also want you to be able to see and evaluate and to recognize some common renal pathology, including calculi disease and congenital anomalies as appropriate for your level of training. We're not trying to make you a radiologist. And describe some various interventional techniques, such as those listed here, to diagnose and treat renal pathology. So one more thing, you do need to know who the Beatles are if you don't know who they are. And double click on this paper over here and you can read about how the Beatles did or may not have via Apple Records finance the discovery of CT scans. Some people say that they did. Others say, yeah, not so much. You need to know these names. You need to know who Tesla is, Damadian, Röntgen, Mansfield, Hounsfield for the CAT scanner, Hounsfield units, and of course you need to know who John, Paul, George, and Ringo are. And if you don't know those, really, seriously, guys, come on. You should know who the Beatles are. I know I'm old, but the Beatles are timeless. Okay. Here's a link to my YouTube channel. You should go watch these videos. Some of them are just a couple of minutes long, 1 or 2 minutes. One goes through a cross-section of the kidneys. The other goes through the adrenal anatomy, renal anatomy. We go through that. I think I posted that separately for you guys to look at. There's a video showing a cystoscopy with a bladder tumor biopsy and another video that shows placement of ureteral stents. And there might be some more goodies up there for you. So click on this and it should take you to my playlist. So here's the learning objectives. Again, you can download these if you want to. It's a Word diagram. Take the PowerPoint out of presentation mode. Double click on this and you should be able to pull all of your learning objectives down. So let's talk about some common indications for renal imaging. Flank or groin or abdominal pain, trauma, especially retroperitoneal trauma or back trauma, blood in the urine, tumors, history of kidney stones, maybe even hyperparathyroidism. Parathyroids control they are our calcium regulators via parathyroid hormone. If someone has frequent and continuing dysuria, it hurts when they pee, we need to find out the function of the kidneys. And if someone has repetitive infections, maybe these repetitive infections are secondary to a congenital anomaly. Yeah, which leads us right to the next one. Sometimes we got to work up those congenital weird things that happen to the kidneys, like congenital absence of a kidney or horseshoe kidney or pelvic kidney. All kinds of weird stuff can happen. Dr. Campbell will talk to you about all those weird things when she does the embryology. And sometimes we need to look at the kidneys before we operate on somebody. There is more than one famous case where a surgeon has gone in, opened up somebody's abdomen and felt around and said, wow, there's a big mass back here. We need to take this puppy out. And guess what they end up taking out? A normal kidney, because they didn't know the anatomy before they went in. So, stuff happens like that. So some imaging techniques for renal disease, a KUB, an abdominal film, IVP, a renal scan, ultrasound, of course, CT scan. Remember, the gold standard for looking for kidney stones is non-contrast. That means no IV contrast and no oral contrast, because the kidney stone will show up as a little white dot. And if you use IV contrast, it makes all the veins and the ureters white and you can't see it. What's MR? How is MRI useful? How is a classic and MRA angiography useful? And we're going to look at all of these things. We're going to look at a cystogram, a urethrogram, retrograde pyelogram. We're going to look inside a bladder using the cystoscope. So here's a renal mass scheme. And it's not really the way that I think about it, but this is one that the school uses. If you see that someone is suspected of having a renal mass, then your next question is it a solid lesion or is it cystic? If it's cystic, it's more likely probably benign. If it's solid, it's probably a cancer. And then we need to know the size of it, and then we need to do the associated workup. Of course, if a patient comes to you for another reason and you happen to scan their belly and all of a sudden the radiologist tells you that there's something on the adrenal gland, that's called an incidentaloma, by the way. Incidentaloma is a word specific to the adrenal gland. Also, if we notice on CAT scan that there's a lump on the kidney, then we need to know, well, where is it? Is it visible? Well, now it is, because we did the CAT scan on it. Is it deep in the tissue? Sure, it's in the retroperitoneum. Where is it at? Well, the abdomen or pelvis. And then we need to find out what caused it. Is it congenital? Is it from an infection? Is it benign or malignant cancer? Et cetera, et cetera. So this is how we work our way through the scheme here to find out if we're looking for a cancer, something that is congenital, or something that is simply cystic. Now, if someone comes in with renal colic, which means that they've had a stone and they know they've had a stone, then the first thing we do is we get a plain film and we look to see if we can see the kidney stone on just a plain film. If we can't, then we might send them over for a ultrasound of the kidney, and a lot of times that includes an ultrasound of the abdomen. If you order ultrasound of the abdomen, they will do the kidneys, and they're going to look for gallstones, the kidney stones. They're going to look for hydronephrosis, and then sometimes we will simply just run them through the CAT scanner. But we can't do that on everybody because it's expensive, and sometimes we'll do what's called an IVP, an intravenous pyelogram. It's a tomogram of the kidneys where we take a bunch of plain films, except we blur out everything on those plain films except the kidneys. I'll show you what that looks like coming up. And of course, most expensive but best for detecting a kidney calculus kidney stone would be a non-contrast helical CT scan. So again, what we need to look at first is when we're looking at our renal mass, we need to know if it's solid or cystic. And then from there, we can work our way down the scheme to see what we got. So there is a nice paper here, and this is the original paper. If you see it, right there's a guy's name, Morton Bosniak. His name is only second on the paper, so I don't know why it's named after him. But we have Bosniak's classification. And if you want to double-click on this, open up this paper. If you want to read it, it's probably too much and too complicated. But here's a coronal version of a CT scan, and you can see that there are multiple cysts here all over this patient's kidneys, all over. This is no doubt polycystic kidney disease, but notice there are cysts here in the liver. So, and the vena cava is a little full and a little thick here. This bothers me. So he could have polycystic kidney disease. He also could have a renal cell carcinoma that is metastasized to the liver. I actually don't know how they read this CT scan. So Bosniak system is very helpful for looking at cyst and giving us a classification for them to tell us there's no cyst, there's simple cyst, there's polycystic disease, which is autosomal dominant, hydronephrosis, and again, that is not a cyst. Hydronephrosis means the ureter and the collecting system are greatly enlarged, usually because there's a blockage distally, et cetera, et cetera. So this is helpful for us to learn a little bit about this classification system. So you do not need to memorize the Bosniak classification. You just need to know that it exists and it's named after this guy Bosniak. But I did put an article here if you'd like to double click on it, download it, and look at it. The classification system is for renal cyst. It's fairly complex and it's subject to change based on increasing resolution of CT scanners. But just know that this classification system exists. So what about with doing ultrasound if we can see some renal cyst? So here's a kidney with a couple of cysts on it, not so bad. Most of the time we don't do anything when we see these. Sometimes these cysts can be ginormous. My father had one found incidentally on a CT scan. My dad died of an abdominal aortic aneurysm that ruptured, and he had a giant cystic lesion on one of his kidneys. I think it was his left kidney. I didn't cause him any pain. He had it for years. And it was back pain that brought him in with a diagnosis of AAA, but it wasn't from the renal cyst. So here on the ultrasound, check out what we can see here. Here's the liver. This right here is the liver, and it's got multiple lesions within it. This is not healthy. These are not cysts. These look like solid masses within the liver. Here's the right kidney, and here's a cyst on that kidney. And we call this area right in here between the kidney and the undersurface of the liver, Morrison's pouch. Morrison's pouch, right in there. So just more pictures of kidneys. Here's an ultrasound. You can see right here is a little bit of liver. And then here's a cyst within that kidney. Same thing, just a simple cyst. So again, looking at renal mass, once we've done the ultrasound, we're going to find out if it's a complex cyst, a simple cyst, or if it's tumor. Kind of like that one with that liver, with those multiple Mets in the liver. So here is, for example, how important polycystic kidney is. It made the front of Time magazine back in 2000. So again, we have, here is kidney here, multiple cysts within the kidney, multiple cysts. Okay, just like this. That's all we're talking about. Best diagnosed using probably ultrasound. You can see them on CAT scan. You can see them quite well on CAT scan. But cheap and easy to diagnose cysts on the kidney or to follow them would be an ultrasound of the kidneys. So you got to read this paper. Please double-click, download this puppy, and read this thing. It's about the evaluation of an incidental kidney or an incidental adrenal mass. And an adrenal mass that we find incidentally is called an incidentaloma. And then it talks about here's a workup for the renal mass detected incidentally on CAT scan. Is the patient symptomatic? Yes. Well, let's go get a CAT scan and send them to a urologist. No. Well, is it a cyst? Is it a big cyst? Is it a really convoluted, complex cyst? Does it need a CAT scan? Are we going to have to biopsy something? Is it growing up the inferior vena cava? That's what kidney cancers like to do before they metastasize. They like to crawl and spread right up the internal vena cava. Nasty disease. So we find this occult mass. Initially, we don't know it's there. That's why we call it occult. But then we scan you, and then we find it. And then we have to know, is it symptomatic or not. If it is symptomatic, we're going to have to go do some more imaging. We're going to have to send you to a urologist for biopsy. And eventually we got to find out if it's a cancer or not. That's really what this lumper mass scheme is trying to show us. How you can use the lumper mass scheme, whether you can see a mass when they walk in and shake your hand. Wow, that's a funny looking mass you've got on your neck. Or is it one that they come in and say, hey, doc, we did a CAT scan looking for my cause of abdominal pain, and they found something on my adrenal gland. Then we have to start here at this node. All right, who discovered X-rays? Well, I'll tell you that history gives credit to this to Wilhelm Röntgen. And if you want to learn a little bit more how X-rays work, I put some links here. They're still active to some YouTube videos. I always do that. I always put in links because I hope it teaches you something over and above what I have time to do. We even have a chemical, Röntgenium, named after Wilhelm Röntgen. So he must have been the discoverer of radiographs. I will tell you, though, that our old buddy Tesla, his name comes up because there are those who say that he had some papers dated a little bit before Röntgen's that showed that Tesla had discovered it. But I think history gives credit to Röntgen for having discovered X-rays. This is interesting here because if you click on this link, they talk about what X-rays are from a physics point of view, how we use them in medicine, and the guys that make these scanners, Siemens, they make some really impressive MR scanners and CT scanners. They have a series of 12 little 1-minute videos that are awesome, that do a much better job than I can. So I would really appreciate it if you would go out there, click on that video, and go learn something about the physics of MRIs and CAT scanners. So here's a plain X-ray of somebody's abdomen, and they have some stones in their bladder, these big giant stones here. But these little things, so this is a bladder stone, these little things are called phlebolyths right here. They're usually calcifications within a blood vessel, or sometimes they can be little pieces of poop that are in, like, for example, the ascending colon or descending colon. The point is these little tiny ones are not in the bladder. It's these big ones here that are the bladder stones. Somebody comes in with these, we got to get them out because they're a source of infection. They act as a nidus for infection. Anyways, if you see those, we got to get them out. Now let's talk about what's the difference between an abdominal film and a KUB. So there's just a little subtle difference here. An abdominal film will have everything that you see here. It will include the diaphragm. It will include the costophrenic angles. It might even include a little bit of the heart. It will definitely show the abdomen, so it's called an abdominal film. And it will go way down past the pubic symphysis. So it'll show us everything. It'll show, in fact, you can even see almost, this is a floating rib here, but the liver you can sort of make out here right at the bottom of that floating rib. And if you look closely, you can see the kidney over here. If you look, you can see that right kidney. I cannot see the left kidney, but I can see the right kidney right there. And then a KUB. KUB means picture of the kidneys, the ureter, and the bladder. So, and that is only going to go from the top of the diaphragm down to the top of the pubic symphysis. And over here, it looks like we have an arrow pointing probably to a great big giant kidney stone in the patient's left ureter. But there's a difference between a KUB and an abdominal film. Now, if I was looking to see if somebody got stabbed in the belly button, I wanted to see if they had any free air for a perforation, I could ask for a KUB or an abdominal film. It really wouldn't matter. But when you order what's called an acute abdominal series, that's how you order it, an acute abdominal series. It includes a upright chest x-ray and a flat and upright abdominal film. And those, they'll give you abdominal films. They will not give you KUBs for that. Okay. So here is this red marking shows the area of an abdominal film. And then over here is the boundaries of a KUB. Okay. Now let's talk about nephrotomograms. This is really hard for students to wrap their head around, but let's take a second here and talk about nephrotomograms. Students always have a hard time with what is a tomogram, what's a CAT scan, etc. So let's go back to that previous slide. Nope, let's start here. And over here on the left, this is called an IVP, an intravenous pyelogram. This is a film that is obtained by injecting intravenous contrast, which is an iodine-containing solution, and it's bad on the kidneys. So if someone has kidney failure or impending kidney failure or pre-renal kidney failure or renal failure, you cannot do intravenous contrast on these patients. But if a normal patient comes in and we want to look at the collecting system of the kidneys, we can either do a CAT scan. If we're looking for a stone, we're going to do a non-contrast CT scan. If we're looking for a mass or a tumor, we're going to use intravenous contrast. So the non-contrast CT scan, no oral contrast, no IV contrast, is done to look for a stone. But if you want a really good CT scan, and CT scan stands for computerized tomography, so intravenous pyelogram is a tomogram, as is a CAT scan. Okay, so if we want to get a picture of the kidneys, we can do either an IVP or a CT scan. Both require the injection of a iodine-containing dye, which is bad for the kidneys. Both of them do. But we get this picture here by having the patient lie on a table, and then we take the X-ray beam and we spin it over their head back and forth like this. And as it's going back and forth, it's taking multiple plane X-rays, okay, plane X-rays. And what it's doing is the beam that we're swinging over their head is focused at the focal plane of where the kidneys are. So everything else is blurry except the kidneys and then where we think the ureters are going to be. So everything else gets blurred out except what we're looking at. So in theory, you could use the same sort of technology to look at the liver or to look at the spleen. You could do a tomogram using plain X-rays to look at the liver or the spleen. IVP is not done that commonly anymore. Almost everybody has CAT scanners. Once in a while, you're still going to see where an IVP can be done and needs to be done. But an IVP is a tomogram, as is a CAT scan. But you can have a nephrogram that isn't an IVP. So a nephrotomogram is a CAT scan. A nephrotomogram is also this picture here, an IVP. But sometimes after the patient has had a CT scan, for whatever reason, we send them back and get a plain film of their abdomen. And they still have contrast in their kidneys that they haven't peed out yet. So we get this picture of contrast in their kidneys, contrast in their ureters, and contrast in their bladder. We didn't mean to, but they just haven't peed it out yet. So that's also a nephrogram. That's a post-CT nephrogram that isn't an IVP, and it's not a tomogram. So think about this for a second. IVP done with plain X-rays. CT scan is a tomography device that instead of just having the tube go over the patient like on a plain X-ray, CT scan swirls around the patient and takes a million tiny pixels of information. They're called voxels, V-O-X-E-L, V-O-X-E-L. They spin around the patient and move the focal plane up and down and take pictures of everything in the body. Okay, that's a CAT scan. But so I give somebody some IV contrast, send them over for their CAT scan. We put them in the tube, and the tube spins around them, gives me a nice, beautiful CAT scan picture. And then I go, you know what? Let's send them back. I need a plain X-ray of their abdomen. And then sometimes you get a picture that kind of looks like, maybe this one over here on the right. It's a nice in-focus abdominal film, and they have contrast in their collecting system down to the bladder. But this is not a tomogram. This is just a plain X-ray with some residual contrast in it. Over here, now this is an IVP because everything's kind of blurry here. Even the kidneys are a little blurry here. But this is a classic IVP. And this is one of the images they took at 10 minutes. So they spun that X-ray source over the patient, back and forth, X-ray, 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 boom. And this is what we got at 10 minutes. This one could just be I just had a CT scan and you took an X-ray of my belly. I hope that makes sense. So here's what a stone would look like on an IVP. Intravenous pyelogram, we give them the contrast, and it shows up as a filling defect. Right there, maybe right there. And this right here looks like either a stricture or peristalsis of the ureter. Cannot be sure. Over here on the right, we see a total blockage. Well, almost total blockage because you can see a little bit of contrast here, but almost a total blockage of contrast. So there's something blocking this, and this patient has hydronephrosis. This is not a normal looking collecting system. This is big and fat and giant. Something's blocking that kidney from being able to let its urine go down to the bladder. So over here, IVP, the stone shows up as an absence of contrast. It's called radiolucent. Okay, so let's take another look. So here's a good example of what I was talking about. This patient had a CAT scan, and they had oral and IV contrast. I know they had IV contrast because I can see the contrast in the collecting system. Okay, goes from the kidneys down the ureter, down into the bladder. I know they had oral contrast because I can see their colon. So they had to drink all of this nasty tasting milkshake stuff. And then we got an X-ray, say like 24 hours later, and guess what? They've got residual contrast, not only in their kidneys, but here in the colon. And the stuff that they drink is not absorbed. So if you're thinking, oh, well, they drank it and it got absorbed and got peed out in the kidneys. No, that's not the way it works with this contrast. It's not absorbed. So over here on the right is an MRI nephrogram. Okay. Is an MRI a tomogram? Yeah, but except it's done with magnets and not with X-ray beam. So same thing, just not an X-ray beam done with magnets. Okay. So let's look at this question. A difference between a KUB and an abdominal film is cost. Nah, they're probably about the same. Presence or absence of diaphragm in the image. Yep, that could be. KUB shows the kidneys, ureters, and bladder. An abdominal film does not. Well, an abdominal film could show all those. KUB is a tomogram. An abdominal film is not. So KUB is not a tomogram, and an abdominal film is not a tomogram. So it looks like, what would you say the answer is? I would say that it's B, that the presence or absence of diaphragms in the image when you're just looking at the film. So an abdominal film is going to have the diaphragms in the image. A KUB may not have the diaphragms in the image. Okay. So an IVP and a post-CAT scan nephrogram, okay, are both obtained via tomography. Well, the post-CT nephrogram isn't really taken via tomography. The CAT scan done right before it was done with the tomogram, but not just the plain X-ray afterwards of somebody's belly after they had a CT scan. Are identical in all respects. Not really. IVP is performed more commonly today than a CT nephrogram. Both rely on an intravenous injection of an iodated contrast agent. And I think that's the right answer. Okay? Hope this makes sense. Don't want to beat it like a dead horse. Okay, so we can also, here's an IVP, and we can diagnose some problems with a prostate by looking at an IVP. So here's a ureter on the right. Here's the patient's ureter on the left. The bladder fills up with contrast. And you see these trabeculations up here. Trabeculations are where the bladder has stretched and the muscle fibers get enormously stretched and they start to thin out. And you can see these when you put a scope in a man's bladder. And it's usually because the prostate, which is right here, you can't see the prostate, but it's the prostate pushing up into the bladder, giving it this kind of concave shape. So down here's the prostate. So normal prostate is here. Normal prostate's right here. Enlarged prostate is here, and it's pushing up into the bladder. It's pinching off the prostatic urethra, which causes the man not to be able to pee very well. So his bladder gets giant, gets really big, and then it gets these trabeculations in it. And we'll show you what those trabeculations look like. Over here, these are trabeculations. This is a bladder that's been really stretched out lots of times. Okay, here's a lot of trabeculations inside a bladder. It says here that these are obstructions from a nodular prostatic hyperplasia that has led to prominent trabeculations seen on the mucosal surface of the bladder. Yep. So a surgical procedure done to relieve this obstruction, all right, so the guys can pee again, is called a transurethral resection of the prostate. And click on this video, and it shows you a TURP being done. Very common. You're going to send more than one of your patients to the urologist because the old guy comes in and says he can't pee, or a young guy comes in and says he can't pee. Some of our medications cause the prostate to swell. And then all of a sudden, guys that could, write their name in the snow now can't anymore. That was a joke. Please laugh. But you get the idea that sometimes guys take medications, and really common ones are like chlortrimeton, which is a people take for allergies. If a man who has an enlarged prostate continues to take chlortrimeton for his allergies, his prostate can swell up and he can't pee. So he might need somebody that needs a TURP. These older guys usually complain of frequency. They're peeing all the time, every 2 hours. They hesitate. They can't start the stream. They have to stand there and wait for the stream to start. They get up a lot at night. There's also an association of sleep apnea with an enlarged prostate. You have to separate those out. Is he getting up because he can't sleep because he has sleep apnea, or is he getting up because he has a big bladder and he can't pee, and he's peeing all through the night? And then he also dribbles. So after he thinks he's done urinating, he still has dribbles. And of course, you can imagine the hygiene issues with this, and it's very frustrating. And so the treatment, of course, is a TURP, a transurethral resection of the prostate. So now let's look at this. This is a renal scan, a nuclear renal scan. It's called a renogram, and it is used to evaluate renal function, renal blood flow, and it's see if a kidney is obstructed, and if so, how much. We can first look at the vascular input to the kidneys, and then we can see the kidneys themselves absorb the radioactive contrast, and then we can see how well over time it washes out. Is there an obstruction downstream that's keeping the kidney from not having a good blood flow to it? So we really are doing this to look at renal function. So here we're looking at 2 minutes, 4 minutes, 10 minutes, 22 minutes, etc. And when we're looking at this, we're hoping that the kidneys are going to light up equal, and then over time they're going to flush that contrast out equally. Okay. So technically, when we do this, it's the same technique and same chemicals as a bone scan. Sestamibi scan, or a parathyroid scan, or a thyroid gland imaging, or biliary tract disease. And while the chemicals can be a little different, it all accomplishes the same end result. And that is, it gives us a way to assess renal function. So the patient goes to the nuclear medicine department, gets an intravenous injection of the radioactive chemical, and then we put them under a Geiger camera. It's called a SPECT camera, S-P-E-C-T, a SPECT camera. It's like a Geiger counter, but it's technically a camera. And then it detects the presence of radiation and can gives us a nice picture then of the function of the kidneys. So let's take a look at this. And here's a good example. Sorry, I went too quick. Here's a good example of someone who has a normal renogram. So here you can see the kidneys lighting up, which means the blood flow to both kidneys is equal, and both kidneys are functioning well because they're lighting up equally. And if you look inside the kidney, you can see the collecting system. Here's the parenchyma of the kidney, okay? And then here is the collecting system of the kidney. So this is like the cortex, sort of, and these would be like the renal pyramids in here. So here's somebody who has hydronephrosis. Over here on the left, we have an IVP. Here we can see the right ureter. Here we can see the left ureter kind of fades out, but we can see it. But this is not normal. Compare the renal pelvis on the left kidney to the right kidney. Left kidney here, big pelvis. Okay, something's blocking this kidney from being able to excrete or function. Something's blocking the drainage of that kidney. So if we want to see, well, is that kidney even still alive, or is it dead? Is it getting any blood flow at all? We can do a renal scan. And here we can see that on these images, we can see the enlarged renal pelvis here. But we also see that whereas the right kidney lights up and gets contrast and it washes itself out of the radioactive contrast material, that the left kidney lights up right away, but it doesn't get rid of its contrast material. Something is wrong with the circulation and obstructing the excretion of that left kidney. So we get a two-way problem here. The blood flow in looks good, but the blood flow out is not very good. And also the drainage from that hydronephrosis area, from that renal medulla down into the ureter, the urine draining is blocked. So we've got poor outflow, poor venous flow, and we also have something blocking the actual output of the kidney itself. So here's another question. So you want to measure renal function of each kidney in a patient with diabetes. What would you order? An ultrasound? Would you measure 24-hour urine output? Renal scan, IVP, or CAT scan? Well, remember, if your patient has diabetes, they might have an elevated serum creatinine, and you don't want to give them any iodinated IV contrast. But the radioactive contrast they can handle. That's okay. The radioactive technetium or sestamebe is fine. But you can't give them any of the iodine, so we can't do an IVP and we can't do a CAT scan. So, of course, what are we going to do? We're going to do a renal scan because we want to look at the function of each kidney. Now, if I measure the urine output, that tells me how much urine both kidneys are putting out in 24 hours, but it doesn't allow me to separate it. It doesn't allow me to say, well, the right kidney put out 100 cc's and the left kidney put out 400 cc's. It doesn't tell me that. So we need a renal scan to tell its function. Okay. So advantages of using ultrasound, probably here, it's relatively inexpensive. It's quick. Most hospitals run ultrasound departments up until midnight. Sometimes they'll even call ultrasound techs in at night to do ultrasounds of the kidneys. There's no radiation. They're portable. This is a machine that I had in my office. It was a Toshiba machine. I had all the bells and whistles, but I sold that puppy. Great machine. But anyways, it's really no radiation. It's quick. It's easy. It's relatively inexpensive, and there is no need for contrast agents. Okay, no need. So let's look at hydronephrosis of the right kidney. So here is an image of a kidney. Okay, and you can see the cortex. Here's the medulla of the kidney. Here's the renal cortex. And here's hydronephrosis. This is fluid inside the collecting system. Okay, this is not normal. So what do? Well, we can drain that. All we got to do is stick a needle in through the kidney, put a wire in, and then we can put a catheter in over that wire. It's pretty cool. It's called a percutaneous nephrostomy tube. The nice thing about this is if somebody comes in with a blockage, say they have a cancer that's pinching off that ureter, and we got to get the kidney functioning again. I want to save the life of the kidney. Eventually, I want to save the life of the patient, but I don't want that kidney to die by being obstructed. So we do a percutaneous nephrostomy tube, and the nice thing is it drains and it comes and drains out into a bag, and it gives me time to figure out what's going on with the kidney. So I drain the kidney, That allows the blood flow into the kidney and the blood flow out of the kidney to resume normally. And then I can relieve this obstruction. The thing about the kidney being in the retroperitoneum is that, let's say, for example, and I'm just making this up because it never happens, but what if the obstruction came so big that the kidney ruptured, or that when we stuck our needle in that we spilled urine all in the retroperitoneum? Well, urine should be, under normal circumstances, sterile. So if we spill it or it leaks or it ruptures into the retroperitoneum, it's not such a big deal. The retroperitoneum will contain that leak. Whereas if the kidney was in the belly and it leaked, you'd have urine all over your belly, bathing your intestines in it. So it turns out that it's a nice thing that the kidneys are retroperitoneal, because we can take care of a blockage from those kidneys. And the fact it's retroperitoneal means it's easy to get to, and we can deal with it. So now we're going to look at solid masses, and we do worry about the ones that are 1.5 centimeters or greater. Here again is an ultrasounded kidney, got a solid mass right here. Here's a big solid mass in a kidney, another one. And the whole kidney here looks almost taken up on this. This is a Wilms tumor. This is a also known as a nephroblastoma, if my embryology is correct. This is what the lead singer for Motley Crue, he had a little daughter. His daughter's name was Skylar. Skylar was about 4 years old, and she died of a Wilms tumor. And if you watch the Netflix special called The Dirt, it's about Motley Crue and those idiots. But his little girl died of a Wilms tumor. But nevertheless, the point is, can you recognize this on an ultrasound? So look at this one here. This is a good ultrasound. This is good resolution here. So we got the kidney is right here. I'm sorry. Kidney is right here. Morrison's pouch is this area here. This is the liver right up here. So liver, kidney, mass. Probably a cancer. Probably a cancer. Here are some CT scans, and we're going to look at, just some normal renal anatomy on a CAT scan. So these are normal looking, and the reason that they show sort of white is this person had oral contrast. You can see the white in the stomach, and they also had IV contrast. So here on this kidney, I can see the ureter here. I can see the ureter in the collecting system here. Here's the aorta, okay, right there. Gallbladder, here's liver, here's the spleen. Over here, normal kidneys, got a renal vein coming over the aorta. The left renal vein comes over the aorta, goes into the infravena cava right there. So these are obviously diseased kidneys. They're shrunken, they're shriveled up. They probably don't work very well. This might be somebody who has total kidney failure and is on dialysis, and their kidneys just basically atrophy with time. They're not getting used. So again, if you want to go learn about CT scans, this is a tomogram, but the radiation source, instead of swinging back and forth across you like a IVP, the radiation source rotates around you in that great big giant gantry is what we call it. So it's taking multiple tomographic images called voxels, and the plane is focused at 1 million different planes throughout your body, and it's creating images at 1 million planes where the beam is focused. So now let's talk about this classic renal anatomy, okay? Let's look first at some normal anatomy. So here's the right kidney, here's the left kidney, all right? Here is the left renal vein crossing over the aorta, okay? And it's going into the infravena cava. And here you can see common bile duct. This is the pancreas right here. There's a pancreas. Here is SMV right here. Here's superior mesenteric artery. Now, over here, this is a normal anatomy right here. But sometimes so here's celiac trunk. Here's superior mesenteric artery, inferior mesenteric artery. So celiac trunk gives blood supply to the stomach, to the spleen, and to the liver. This gives blood supply to the small bowel, and this gives blood supply to the descending colon. Sometimes the SMA pinches the left renal vein. and it causes a mild obstruction in the left renal vein. We call that nutcracker syndrome. I have never seen a case of it that I know of. I'm not sure I would have recognized it on CAT scan if I'd seen it. But anyways, it's a surgical repair to fix it. We divide the renal vein. So we divide the renal vein off of the infravena cava, and then we just implant it down a little more distal so it doesn't and can't get pinched by the superior mesenteric artery. Okay. It looks really easy here, because everything's out of the way, but in reality, you got the guts are in the way and the mesentery's in the way, and this is in the retroperitoneum, all this repair, and nobody likes to sew onto the vena cava because that makes your sphincter tight and you'll break a pencil because you're so nervous sewing right here on the cava. This is an area that would make me very nervous. So anyways, so this is kind of, again, really what nutcracker is. And now we move over to something called SMA syndrome. Same idea, but so here is the superior mesenteric artery right here, and it's crossing over the left renal vein, except in this case, the patient has no body fat back here. Normally there's body fat over this, in this area, and they have no body fat, and just the weight of the artery, the superior mesenteric artery and its tributaries, pinches off the duodenum, the retroperitoneal portion of the duodenum, as it crosses over the aorta and the spine back here. So the duodenum right here gets pinched. So people start puking. And who gets this? People who have absolutely no body fat. So anorexics, mostly young ladies, but not always young ladies, but mostly young ladies who come in and have lost a huge amount of weight and they're vomiting because their SMA artery, the superior mesenteric artery, is pinching off their duodenum. It doesn't cause nutcracker. I don't know why. I don't know why you don't get nutcracker and SMA together. I don't know. I've never heard of it. Seems like you would. But the SMA pinches off the duodenum and food can't get through. I have seen in my surgical career probably 3 or 4 cases of this. So it's rare, but it's not so rare that you won't see it. You got to be open to the possibility of SMA syndrome. What is the treatment for SMA syndrome? Resume feedings very slowly. Sometimes it's tube feedings. Sometimes you need to put a feeding tube down past this portion of the duodenum, put the feeding tube into the jejunum over here. So duodenum, jejunum comes around and down here. You got to feed them down here. They have to gain weight slowly. This is a classic story of when the Americans went into the Nazi concentration camps and immediately wanted to feed all of these starved prisoners in that horrible scene that we all know. And they were puking. And of course, imagine, you can't understand why that is. But here's what they were seeing is that we would give them bread to eat, and the bread would just fill up in their stomachs and make their duodenum massive. And it was getting pinched off by their superior mesenteric artery right here. And the food couldn't get past the superior mesenteric artery. So these people who are starving are all of a sudden, you're giving them bread and they're just puking it back up. And they don't understand. And so we had to go in and take all the bread back. And they're like, what are you doing? We're starving. Please give us the food. And we're like, yeah, I know, but you're puking it up because you have SMA syndrome, and we're going to feed you slowly. And so that's the treatment for it. Resume slow feedings. Horrible, horrible disease. Okay, so compression of the duodenum by the SMA. What is that called? Well, it's called SMA syndrome. Okay, compression of the left renal vein by the SMA is called nutcracker syndrome. Okay. So the gold standard to look for a kidney stone is a non-contrast CT scan. So here it is. Non-contrast. There is no contrast in this anywhere at all. There's no contrast in the ureters, no contrast in the guts, nothing. Non-contrast CT scan. Gold standard for looking for a kidney stone. Okay. How do we get those kidney stones out? Well, we can do something called percutaneous, sort of the same thing. We can do a percutaneous nephrostomy where we put a pretty good sized instrument into the kidney, and then we can break them up either with more sound waves directed at them, or we can put graspers in and break them up, and hopefully they'll pee out by putting a stent in the ureter, keep the ureter open, and then the stones will fall out past the stent. Or we can go up with a ureteroscope and take out these calculi too. I make it sound easy, but it's not. These have to be done under general anesthesia. Of course, you can imagine the pain of kidney stones is horrible. They say it's the worst pain ever. So here are some CT scans which show kidney stones. Here's a kidney stone with a right hydronephrosis. Check that out. That collecting system is giant compared to the left kidney. Here's a kidney stone. This is colon. It has poop in it. That's what you're seeing here. Here's a kidney stone at the ureteropelvic junction, which is where most kidney stones are located. Most kidney stones have a hard time maneuvering in the ureter over the brim, the pelvic brim. And that's where what we call the UPJ, uretero-pelvic junction. This is where most of our kidney stones are. So here is an example of pyelonephritis. This is pus in the kidney, infection in the kidney. Here, this patient has so much infection that they actually have an air-forming organism causing their pyelonephritis, the pus in the kidney. All the air-forming organisms that you know can get in there and cause that. Or this could be that they've already instrumented this kidney and maybe gone up and tried to drain it and got air into the kidney that way. But I doubt it because this kidney's got pus in it right here. Over here, we got an abscess right there. They've used IV contrast in this CAT scan because it's lighting up the kidney. There's really no oral contrast that I see. IV contrast, kidney, here's the collecting system, here's pus. And this is what it looks like. Good old-fashioned pus. You open up the kidney, and there it is. Here's collecting system that's dilated. It shouldn't look like this. These are abnormal. Okay, so the gold standard to diagnose kidney stones, non-contrast CT scan. Okay. What if your CAT scanner is not working in your hospital? What if it's down? What if it's broken? Well, then you can order an IVP. Old-fashioned test, but it works just as well, and they can do it. But you got to make sure your patient's creatinine is normal. The serum creatinine's got to be normal, or they're not going to do your IVP because the iodine dye that they inject intravenously can kill the kidney. So you got to be aware of that. So here's renal cell carcinoma. This is an evil player. Okay, on this CAT scan here, we see the kidneys. Obviously, this patient's had oral contrast and IV contrast right here because it lights up. And here's a solid mass. Okay, we don't know what that is. It's just a solid mass. Pretty good chance, though, based on the size, it's a kidney tumor. Here is a giant solid tumor here. This is necrotic. Those arrows are showing not only the capsule of the tumor, but it's showing some necrotic areas within the kidney itself. Here's a renal cell carcinoma. This is a bad player. Here's a renal cell carcinoma in the left kidney, and it is growing into the left renal vein all the way over into the inferior vena cava. And over here, giant tumor in the left kidney, left renal cell carcinoma, and it likes to grow into the inferior vena cava, and it will grow right up into the right atrium. It'll grow right up into it. Nasty player, and it can embolize and break off, and you can get tumor. You can get pulmonary embolism from kidney tumor. Think about that. Wow. So here's some more renal cell carcinomas. Here's a picture showing how that kidney tumor grows into the, here in this case, the left renal vein. It's growing into the inferior vena cava. Same thing here. Kidney tumor growing into the inferior vena cava. Hydronephrosis, the kidney's blocked off. It can't drain. Same thing here. Big renal mass growing up, this thrombus growing up into the inferior vena cava. So that's what's unique about renal cell carcinoma. So here it is. Another nice picture growing all the way up, going right up into the right atrium. Same thing here. What do we do to prevent that? Well, we can put a balloon in. So here we've got a cannula in the aorta, cannula in the SVC, put them on bypass. And then we can put this balloon catheter up and pull this tumor out. We can just strip the tumor out. It's not like it's growing into the wall of the cava. It's just growing up the cava. Either way, by the time, your days are numbered by the time you have to do this, though. But they're doing this to try to save, blood flow, to recreate blood flow and let you get venous blood flow back to your heart. So metastatic disease from renal cell carcinoma. This is a bone scan. This is a normal bone scan. We've injected somebody again with radioactive technetium or sestamebe, whatever the chemical is, and it goes right to the bones. And you're looking for symmetry. So here's a little dot here and a little dot here on their kneecap. Those are symmetric. That one's a little darker. He's probably got a little arthritis in his kneecap. His bladder is filled with the radioactive chemical. That's normal. That's normal. He's got a little radioactive tracer here in his right kidney. And over here is somebody where the tumor has spread all over to the bone. This would be metastatic renal cell carcinoma. And without the history, this could also be somebody who has prostate cancer too. They would look very similar on bone scan. So stage 1, got a tumor confined to the kidney. Stage 2, it's greater than 7 centimeters and it's beginning to pinch off and obstruct the kidney. Here it's obstructed the kidney and it's grown up the cava. Stage 4, it's spread to lymph nodes and it's on its way up towards your heart. Bad player. So what about MRI? Well, who invented MRI? Click there if you want to find out. See these two guys down here? Mansfeld and Lauterbur. I think they shared the Nobel Prize. But this dude right here, Damadian, this guy right here is given credit for having found the way to take your NMR spectroscopy that you used in organic chemistry to find out what your molecular structure of your compound was. This dude figured out a way to make a picture out of it. So think about how smart that guy is. I'll never be that smart. That is amazing. So they handed him the Nobel Prize, and the strength of the magnets that are used are measured in Teslas. So I think this guy, this is a good story. I'd have to go back and reread this, but this guy invented it, and for some reason, these two guys got the Nobel Prize for it. He got cut out of it for some reason. But anyways, these are MR images. Again, you can see little tiny cysts here in the kidneys. Here's the spleen. Here's the liver. Here's the right kidney. Here's the left kidney. Same thing over here. Left kidney, right kidney, spleen, stomach, liver. But these are MR images, okay? So the advantages is it doesn't require any radiation, and you can do them upright. This is a chair. This is an upright CT scanner. You go and sit in a chair. You don't have to lay in that tube. There's no radiation. It's all done with magnets. And some medical implants you can do. If somebody has little tiny skin staples from surgery, the patient will tell you that the skin staples got warm. They could feel the warmth in them. If you have an artificial joint or something like that. But you still have to be careful. You can't go in and have somebody with, metal earrings in, or it'll rip their earlobes off because these magnets are pretty strong. Good images, though. They're getting better all the time. So disadvantages, some of these, if your patient has a pacemaker, the magnet can turn the pacemaker off. It won't rip it out of their chest, but it'll turn it off. If they've had aneurysm clips, it could potentially pull on those clips in their brain. You don't want that. It could pull on a insulin pump. If they've had a little shrapnel in their eye, they're a construction worker or a welder, it could pull that piece of shrapnel right out through the cornea. Cochlear implants, it can cause crazy loud noises in those implants, and could, in theory, pull out intrauterine devices. And here's probably the biggest. This is probably the biggest problem that I had in practice is an MR scanner. If you've never had one, they're crazy claustrophobic. They fit around you really tight. And a big guy like me, when I get in there and had my head scanned, they give you headphones and you turn on the rock music and that helps, and you close your eyes. But if you open your eyes and you realize that you feel like you're buried alive because these things are pretty claustrophobic, you would do a good deed to give your patient a prescription for anti-anxiety medication before they have their MRI if they're claustrophobic. Okay. The other thing is they're loud. You'll hear this banging, bang, 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 bang all the time as it's taking pictures, as the magnets are rotating around you. And if you want to see how strong the magnet is, click on this link here, and it shows how fast it pulls in an oxygen tube into the scanner. So just shows you how crazy strong those magnets are. So now let's talk about angiograms. We've got to figure out, sometimes your patient will come to you with hypertension and renal artery stenosis right here, renal artery stenosis. That can be a cause of hypertension because the kidney down here sees this stenosis as, hey, I'm not getting enough blood. So what does the body do to increase blood? Well, remember angiotensin and all those things? Well, all the body knows how to do is increase the blood pressure. So it increases the preload to the kidney and by causing hypertension. So not everybody that has hypertension needs to have an angiogram of their kidney, but you need to do a physical exam. Listen, you might hear a bruit, you might not, but you might. Put your stethoscope on their back or in their flank. Listen carefully and see if you can hear a bruit. Make sure you're not listening to the inferior epigastric artery, though. If you put your stethoscope on the mid-axillary, or I'm sorry, the mid-clavicular line, or even the mid-axillary line, you got to be careful where you put it. You might hear a bruit, and that's not the renal artery you're listening to. That's the epigastric arteries. So here's a good example of stenosis of the renal artery right there. So we do a classic angiogram. We run a catheter up through your femoral artery and into the iliacs and then up through the aorta, and we cannulate the renal artery and we shoot some contrast in there, and we find they have renal artery stenosis right here. Renal artery stenosis. What is the physiology behind renal artery stenosis hypertension, and how would you treat it? Well, the treatment is to go in and do an angioplasty or put a stent in to open that up so that we can give the blood flow back to the kidney. Okay. Here's what's called a retrograde pyelogram. Why would I do this? Trauma patients sometimes, or we think that there's a blockage proximally and the CAT scan won't show it to me, or there is not good blood flow to the kidneys or whatever, but I need to get a picture of the collecting system, and I'm going to do it backwards. I'm going to go up the urethra through the bladder, and I'm going to inject contrast into the ureters, the left ureter, the right ureter, and I'm going to shoot some dye up there. I'm going to take a picture. So contrast is injected from the urethra and directly into the ureters, back up into the kidney. So here's the direction of the injection of the contrast from urethra down here up into the ureters. So we would have to do this via cystoscopy, okay, which is kind of the next thing we're going to talk about. So I'd put a ureteroscope up through the urethra into the bladder, and then I would cannulate the opening of the ureter. I cannulate it, and then I put a little stent up there, and then I shoot some contrast, shoot some iodinated contrast up there and take some pictures. Then I pull the endoscope back down, and then I go up this ureter and I shoot some pictures. So this is called a ureteroscope. And sometimes we go up there and guess what? We can find, you guessed it, we can find stones, and we can take those stones out like what we're seeing here. Some stones get really pretty big, and you can go up and get them out this way. You also can do lithotripsy, and sorry, but there's a link here that shows them using using sound lithotripsy and also using laser lithotripsy to get those stones out. And it's not like the stones are always free floating. Sometimes the stones are these barbed, nasty little creatures that are stuck to the ureter. So it's not like you can just go pull them out. Sometimes they're actually like grown into the wall of the ureter, and not very pleasant. Really, people that have kidney stones, I have total sympathy for. Cystogram, same thing. Patient comes in with a car wreck, and you see that the classic teaching is they come in a car wreck, pull their pants off, and you see that they have blood at the urethral meatus. And in this case, let's assume it's a man. He's got blood coming from the tip of the penis, the urethral meatus. You do a rectal exam. You can't feel his prostate exam. And you take an x-ray and you go, oh, crap, he's got a busted pelvis. His pubic symphysis is ripped apart. I need to see if his urethra has been ripped apart. So we take a little needle, a blunt needle, not a sharp one, a blunt needle, put it into the urethra, and we inject contrast backwards. And that's called a urethrogram. So right here's the urethrogram with a cystogram. Okay, so here's a urethrogram and cystogram. And here we see contrast leaking out. So he's obviously got a bladder rupture. Same thing over here. We have contrast leaking out. So he's got probably a little tear in his bladder and urine's leaking out. And again, remember, bladder subperitoneal. That's a good thing in this case. So it's not going to go floating around here with his intestines. That urine is going to stay in that subperitoneal space. And we can, actually the treatment for this could be, depending on what he needs, we could either open up his belly and fix the hole in the bladder, or we can just put a Foley catheter in and let it heal on its own. So, and I think I show that coming up here in a sec, a Foley catheter. So a voiding cyst urethrogram, same thing. We put in a little catheter up to the bladder, fill the bladder, inject up into the ureter, and then we ask the patient to go pee. And then we take x-rays after they're done to see how much empties out. You want to look at one being done, there's a link there. Okay, go take a look. So this test can be done to assess the lower GI tract for congenital malformations, fistulas. For example, sometimes, what if I injected contrast here and instead of going up the ureter, it went right into the colon? You'd be like, what? Well, some diseases of the colon can grow into the bladder. That's called a fistula, colovesical fistula. Colo and vesicle, vesicle means bladder, so colovesical fistula. So we need to assess the integrity of the bladder after we've done bladder repair surgery. See if there's a stricture in a urethra or if there's ureteral reflux. So, and I can't see that here, but that's what they're telling me this patient had. So on this previous patient, on this other film, so let's say I go in and I sew that up. Then a week to 10 days later, I do one of these, and then I need to see if my repair held and they're not leaking urine anymore. Okay. So good old-fashioned cystoscopy allows us to look directly into the bladder, and here we can see those trabeculations that we were talking about. Women get them too, but mostly seen in men. Here's a stone. There is this is a rigid cystoscope, and of course this is a flexible cystoscope. Okay, you want to check it out, see it being done, click right there, and it'll take you to another video in a male patient, and this will show you cystoscopy here also. So we suspect a patient has a bladder cancer. The best test to confirm the diagnosis is CT scan. Well, it may not show. It might be a really small tumor, may not show in the bladder. Cystoscopy. Yeah, I could go in and take a look at it. That seems good. Cystography, voiding cyst urethrogram, or an IVP. I would think the best diagnosis would be the one where I go look directly in the bladder and take a look. That to me seems like the best answer. Okay. So that's about it. There's a lot of information here. If you got any questions, hit me with email, and appreciate your time and effort. Please do what you can to look at those videos that I've put in here. It's very hard for me to explain some of these radiological techniques and endoscopic techniques unless you can actually go look at them on YouTube. When I was in med school, we didn't have YouTube. You guys do. It's an amazing teaching tool, and I try to pick good images. I don't choose just any image. I actually look at like 10 or 15 before I put a link to one up there that I think is good. Okay. So anyways, if you have any questions, you know where I'm at. Hope you enjoyed the presentation. Thank you.